And so my job today is to talk about critical coronary artery disease in PAD patients. Here's my disclosure. So we all know that patients with peripheral arterial disease die of coronary disease. They do not die of their peripheral vascular disease. This coronary disease is often unrecognized because the patients are sedentary, they don't have chest pain, they don't have symptoms, and they in general get suboptimal care. This is really highlighted by the fact that patients with peripheral arterial disease are more likely to die than patients who have had a myocardial infarction. That sounds kind of strange, right? If you have had such bad heart disease that you had an MI, why don't you die at a higher rate than those with peripheral arterial disease? Well, it's because you're under the care of a cardiologist, you're getting stented, you're getting treated, and you know you have heart disease. But if you have peripheral arterial disease, you don't have symptoms, you don't recognize it, and you're not treated, and you die. Well, why do you die? Well, it's because you have coronary artery disease. For 50 years, we have known that peripheral arterial disease patients have coronary disease, and that's been proved by coronary angiography. These are a literature review. More than 50% of all patients with PAD have documented coronary disease by coronary angiography. Well, what do you do when you have that coronary angiogram and you show that you have these lesions? Well, you look at them and you say, gee, that looks pretty bad, I better put in a stent. But half the time, you'll be wrong, because visual assessment of the degree of stenosis that you see on the coronary angiogram doesn't tell you if that stenosis is actually obstructing blood flow and if the patient will get a benefit from a stent. In order to find that out, you have to measure fractional flow reserve. So FFR is measured in the cath lab with a pressure wire, and it's distal pressure divided by proximal pressure under conditions of maximum hyperemia, which is given by adenosine. This is like an ankle brachial index for the heart. If it's less than 0.8, it's significant and it would benefit from a stent. This has been proved very, very well in the coronary literature, and this is on the guidelines of standard of care. Well, can you do this now non-invasively? Well, if you do a coronary CT scan, you can reliably determine do you or do you not have coronary artery disease on the basis of the CT scan. But just like the coronary angiogram, the CT scan doesn't tell you if it's significant. So you look on the right, you look at these lesions on the CT scan, which one is obstructing blood flow and which one needs to be stented. The other problem with peripheral vascular disease patients is they have a lot of calcium. And if there's calcium on the coronary CT scan, you cannot tell what's going on. And the guidelines say you should not do coronary CT if the calcium score is greater than 400. Well, if you now do computational analysis of that coronary CT scan data, you can compute coronary blood flow non-invasively, and you can now get that fractional flow reserve computationally. And here you see that when the FFR-CT is less than 0.8, that's significant, and it highlights in red and yellow. And if it's greater than 0.8, it's green and blue and does not need to be treated. Well, this CT-derived FFR now gives you a three-dimensional map of FFR values throughout the coronary tree. And here you can see very clearly a very significant LAD stenosis with an FFR of 0.43. So you can non-invasively differentiate ischemia-producing coronary lesions from non-ischemia coronary lesions and which patient needs to go to the cath lab and get revascularized. This is FDA cleared, Medicare reimbursed, private insurance coverage and reimbursement. But it's not been used in patients with peripheral vascular disease. So now, is this something that could be of value with those high-risk PAD patients who are dying of heart disease? So in order to determine what is the prevalence of significant coronary disease, There's a prospective trial in Latvia, which is now doing patients who are electively going to our operating room for peripheral vascular disease and getting a coronary CT scan and an FFR-CT evaluation. None of these patients have symptoms of heart disease, no chest pain, no coronary history. And yes, they do have calcium. The average calcium score is greater than 1,000 in these patients. None of them have any symptoms yet. 7% have left main coronary stenosis. This is a lethal lesion. And you can, despite extensive calcium, look at the right coronary artery, 70% stenosis on CT scan, no hemodynamic significance as you look at the blue. The left coronary artery has a less than 50% stenosis by CT, yet it has a very severe stenosis. This is the spectrum of disease that you see on asymptomatic chest pain-wise coronary patients. These are all peripheral patients without coronary symptoms. And if you now look at what the prevalence of disease is, 2 out of 3 of those asymptomatic peripheral arterial patients have very significant coronary disease that needs treatment. 40% are single vessel disease, as you see here in the right coronary artery, and 60% have multivessel disease. More than 60% have very severe ischemia with an FFR less than 0.75. So what do you do with these patients? You now see this terrible coronary disease. They're asymptomatic, and yet they have a critical limb ischemia. They need to go to the operating room. So in fact, that is what is being done with these patients. And they do well. You can get sick patients through every operation with good anesthesia. Now, post-operatively, electively, they are now going to the cath lab, and they're getting coronary angiography, and 37% of them have elective post-op coronary revascularization. Here's an example. You see a very focal LAD lesion, which is treated with a stent. This is a 63-year-old man with left main and right coronary artery disease. He needed a coronary bypass. He got that after his leg was revascularized, and he's done well 1 year later. So the overall results are good. 1/3 of the patients get post-vascular surgery coronary revascularization and do well. So in conclusion, preoperative evaluation of PAD patients with coronary CT and FFR shows that there's a very high prevalence of unsuspected silent coronary ischemia. Identifying this ischemia, optimizing medical care, and doing staged peripheral and coronary revascularization can improve the long-term outcome of patients with peripheral arterial disease. Thank you.